بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. It's always a pleasure and an honor to be among my professors and colleagues here today in this meeting, share our knowledge, our experiences. In the following next few minutes, I'll try to give a brief review about the 3D anatomy of the larynx. Try to share with you how we radiologists can see the larynx. What do we search for to help our juniors examine the larynx and see if there is an abnormality, to see its level, its extension, and so on. There is an interesting fact that I've come through preparing this lecture, that infants can breastfeed and breathe at the same time. We adults can do that. This is called the obligate nose breathing. In babies, the larynx sits a little bit higher, and with further elevation during the swallowing, the epiglottis is able to slide up behind the soft palate, thus locking the pharynx into the nasopharynx, thus enabling the baby to breastfeed and breathe at the same time. This disappears during about 2 to 6 years old. This is an interesting fact. I didn't know that before. Our agenda consists of the brief about the laryngeal growth 3D anatomy and the imaging techniques and the imaging anatomy, as well as the scanning for the laryngeal cancer. We have some take-home messages about the 3D anatomy, and I want everybody to remember two words: the arytenoid cartilage as well as the laryngeal ventricles. Those are very important anatomical landmarks that we need to know while examining the larynx: the arytenoid cartilage as well as the laryngeal ventricles. We'll try to know how we radiologists detect any early abnormality of the larynx, how to determine its level and its extension. So the anatomy of the larynx. The larynx is a system of mucosal folds supported by some cartilaginous framework. Tension and movement of the mucosal folds is affected by the action of some small muscles, thus causing us to speak and form different sounds. It's about 5 to 7 centimeters long, starts about the tip of the epiglottis. Well, the epiglottis have two components. One is a little bit higher than the hyoid bone, and its rest is below the hyoid bone. We'll see about that later. And it ends about the lower end of the cricoid cartilage opposite the sixth cervical vertebrae. The gross anatomy of the larynx consists of some cartilage, muscles, cavities, and spaces, while radiologically speaking, we have a different categorization for that. Looking at the larynx from the anterior, we have the hyoid bone. It's not a part of the larynx, but it can mark the beginning of the larynx. We have the thyroid cartilage. Let me get the pointer. You can see that? Okay. So we have the hyoid bone, we have the thyroid cartilage, the cricoid cartilage. From posteriorly, we can see the posterior part of the cricoid cartilage, which is much bigger than the anterior part. We have the other paired cartilage, we'll talk about them. And then we have the lateral view of the larynx. This is a very important space, which is the pre-laryngeal space. It only contains fat. This is the hyoid bone. As I stated, it's not a part of the larynx, but it's a very important anatomical landmark to determine which level that we are while examining. It lies anterior to the epiglottis. Radiologically speaking, we have some key anatomical features, including the cartilage, the level, and the spaces and the borders. And one important thing about the spaces that they need to be patent. Anything occupying these spaces is abnormal, so the spaces of the larynx need to be patent, and the borders of the larynx they define which abnormality can be intralaryngeal or has an extralaryngeal extension. So we'll talk about those 4 components, starting with the borders. The upper border of the larynx consists of the laryngeal inlet with the superior porter of the epiglottis. The lateral porter is formed by the aryepiglottic folds and some smaller tubercles, the cuneiform, the carniculate, and the interarytenoid notches. Also, we see those spaces need to be spaces. Spaces needs to be spaces. No soft tissue should be in there. We have the laryngeal vestibule, which is the cavity of the larynx itself. We have the laryngeal ventricles, and we said this is one of the 2 important messages that I need to deliver today, which are the laryngeal ventricles and the arytenoid cartilage. Do not forget that. So the laryngeal ventricles is a very important anatomical landmark, as it lies superior to the true vocal cords, and they separate the true vocal cords from the false vocal cords. So this is a very important and some landmark to know, because if you find any abnormality, you need to know whether it is supraglottic or glottic or subglottic abnormality. How to do that? By identifying the laryngeal ventricles. We all know that there is some unburned cartilage like the epiglottis and then the thyroid cartilage and the cricoid cartilage, which is, by the way, is the only complete ring around the larynx and comes from the Latin word cricus, which means ring. We have some buried cartilage, the arytenoid cartilage, and the most smaller ones, which is the cornicate cartilage, as well as the cuneiform cartilage. If I have to choose one of those cartilage to emphasize about, will be the arytenoid cartilage. Those one, those arytenoid cartilage marks the true vocal cords. So, in order to identify the true vocal cords, you need to identify the arytenoid cartilage first. If you saw those, you know that what is attached to them is the true vocal cords. So this is the glottic level. Everything above is the supraglottic. Everything below is the subglottic level. So you need to identify the arytenoid cartilage, and I will show you how in a few minutes. Yes, the number here is the level. This is a coronal CT image of the larynx. You can see here, this is the true vocal cords. This is the laryngeal ventricle. Immediately below the laryngeal ventricle, we have the true vocal cord, and above that is the false vocal cord, and all this level up to the hyoid bone is the supraglottis. This is the glottis level, and everything below till the cricoid cartilage is the subglottis level. Each one of those levels has its own contents and thus its own pathology. Moving on to the spaces, again, spaces need to be spaces, nothing should be in here, and the most important of them is the ventricular fold, which marks the superior level above the true vocal cord. We have two more important spaces which can be a way of extinction of any abnormality, especially tumors, which is the paraglottic space as well as the preglottic space. Both of them should only contain fat. Either in CT or MRI images, they only contain fat. So we have the paraglottic space, which lies laterally here between the larynx and the thyroid cartilage, the thyroid membrane. Any tumor can spread into here, and as well as the preglottic space. We can see it here in the sagittal images in the CT and the MRI. It should only contain space. Any soft tissue density here is abnormal. Cycloperic images here, you can see the fat here in the epiglottic space, which appears a little bit yellowish. Have the false vocal cords, and below that, the arytenoid cartilage, which can attach here to the true vocal cords. So you can see the arytenoid cartilage, you can see the true vocal cords. Below that is the subglottis with the cricoid cartilage. Here is the only complete ring, and we can see the subglottis in the tracheal rings clearly. Again, this is the coronal cadaveric image specimen. You can see here the laryngeal ventricle. Above that is the false vocal cord. Below that is the true vocal cord. See, you can see the level so easily. The sagittal cadaveric image, you have here the laryngeal ventricle. Above that is the false vocal cord. This is very important. If you only can identify the level, you can identify any abnormality and you can see its extinction. So this is the laryngeal ventricle, the false vocal cord, the true vocal cord, and so on. This is the epiglottic space, only containing fat, as we said, and this is the hyoid bone, and this is the trachea. This is part of the cricoid cartilage. So, how do you image the larynx? And by the way, this image is how the ancients used to imagine our airway. This is an ancient imaging. This is supposed to be the trachea, and those are the lungs. Is it CT or MRI? Well, usually the CT is more than enough. Post-contrast CT of the larynx can depict a very beautiful image of the larynx with any abnormality, and it has a very important value in reviewing any abnormality or tumor in the larynx. We only do MRI in the controversial cases where the CT can't give us all the data that you need, and the CT also have an advantage of the very shorter time than MRI. We don't ask the patient to do anything. We don't ask the patient to hold his breath or swallow, whatever, because if you said anything to the patient, he'll get nervous and start breathing fastly, and you'll lose your examination. So CT is always more than enough in examining the larynx, unless in any small controversial cases where we can go to the MRI and further investigate the cases. We'll get to some CT images, and as we said, it's very, very, very important to know where you are. You don't need to get lost in the cuts, and you don't know if you're supraglottic, glottic, infraglottic. So how we do that? We all can see the mandible. Yes. يعني I think ما حدش يغلط في المانdible. We'll see a smaller mandible behind the mandible. You can see it, a smaller mandible here behind the mandible. This is the hyoid bone. So this marks the start, the upper end of the larynx. So if you see a mandible, look in the cuts to see a smaller mandible. This is the start of the larynx. You can see a smaller line here. This is the epiglottis. Further down, this is the remaining of the mandible. You can see the glottis. All of this, we are at the subglottic level. We have the piriform fossa. We have the lateral border of the larynx marked by the arabiglottic folds. And you should, after identifying the hyoid bone, you should look for two bright spots here. Those are the arytenoid cartilage. If you find those two spots, just immediately in front of them you have the true vocal cords. So this is the glottic level. So this is the supraglottic level. It's very good. This is the glottic level, and down you can see the cricoid cartilage. This is the infraglottic level. You can see a more detailed image in just a minute. This is a patient who tried to hold his breath while examination. You can see the approximation of the two true vocal cords. How we know that? We have the true arytenoid cartilage. So anterior to it, this is the true vocal cord, but the patient held his breath while examining. So the two vocal cords opposed together. We had to re-examine the patient to try to separate the true vocal cords from each other. Again, this is the more detailed image in the axial. This is the hyoid bone, as we all agree. This is a small mandible, a mini mandible in the neck. Behind it, you can see the the epiglottis. You can see PAS, that's the pre-epiglottic space. It only contains this is the PAS. It's continuous laterally with the paraglottic space superiorly. So we have the arabiglottic folds, which marks the lateral borders of the larynx. Again, this is the thyroid cartilage. We are not in the glottic level yet. Why is that? Because we didn't reach to the arytenoid cartilage yet. When you find the arytenoid cartilage, you are in the glottic level. So this is the true vocal cord. Just above it, you have the false folds. Can we see the laryngeal ventricle in the axial images? No. You should search for them in the coronal or the sagittal images, but they do not appear because they are very, very, very thin. You can see in the axial images, but we rely on the axial images on the arytenoid cartilage. This is the glottic level, supraglottic level, supraglottic level. You see the hyoid bone, and then you see the cricoid cartilage. You are in the infraglottic level. Yes, but there are selected images. They are not all the body. Yes, this is a very important. This is the coronal view. How you identify the level in the coronal view? You can search for the laryngeal ventricle. Above that is the supraglottis, the false vocal cord. Below it is the true vocal cord, and at the level of the cricoid cartilage, you have the infraglottic cord. Again, this is the pre-epiglottic space. It should only contain fat, the false vocal cord, the true vocal cord, this glottis, supraglottis, and infraglottis level. We are cutting here through the cricoid cartilage. The MRI can give us more detailed images, but it's a major drawback. It needs a lot of time. If the patient swallowed, spoken, or moved during the examination, you will have a very hazy image. You can't see any anatomy. Okay, so how we are scanning for the laryngeal cancer? What do we do as a radiologist? How we see if there is an abnormality? And before continuing, this is a CT image of a mummy. They try to replicate the 3D specimen of the laryngeal structures of a mummy. They try to imagine how it voiced like. What its voice was like. And it was a very interesting experience. They tried to replicate the voice of a mummy. Okay, in most institutions, CT is preferred imaging method for evaluation of the laryngeal cancer. As we said, the MRI is used in complementary problem-solving tool when the CT does not provide all the information prior to therapy. So I'll try to give you how we radiologists think. This is a beautiful image of the Taj Mahal, and we'll need that image now. We always look for the symmetry. What's important about this image, it's totally symmetrical. What's right is also on the left. We look like that. Everything on the right should be a mirror image of everything on the left. So we look for the symmetry. Another thing, we look for the spaces. We said that spaces should be spaces. So the sky should be a sky. If you see any abnormality here, it is an abnormality. So we look for the spaces, we look for the images, we check for density. The building should be building, the fat should be fat, the cartilage should be cartilage. Any abnormality is abnormality. And we check for cartilage, and if we find abnormality, you have to determine which level it is and which extension of it. So if you find abnormality, what do? We first check its level. We need to know which level we are in. Are we in the glottic space, subglottic, or supraglottic? We need to check the spaces, the epiglottic space, the paraglottic space. We need to check for the anterior measure, which only fat. We need to check if there is any cartilage invasion. And let me say a word or two about cartilage. How do we radiologists know that this cartilage is affected? We have three signs. It's either eroded, means it's becoming thinner, or sclerosed, it's becoming whiter, or it has a transcartilage tumor extension. The tumor is deep and superficial to the cartilage. This cartilage is affected. Even if it has a normal CT image, if the tumor is at both sides of the cartilage, this cartilage is invaded. So it's eroded, sclerosed, or has a trans-tumor extension through the cartilage. This cartilage is infiltrated. And we also see the metastasis mainly because of the lymph nodes. As we said, we have the supraglottic and the subglottic and the glottic cancer and the C levels that we spoke about. The rule of imaging is to delineate the site and extension of the mass, show the invasion of the epiglottic space, paraglottic space, and so on. A word or two about the three different types of the laryngeal cancer. The supraglottic cancer can invade the epiglottic space, can also invade the anterior commissure, the glottis, the glottic space, and the lymphatic spread at this cancer is common. The glottic carcinoma typically arises from the anterior half of the vocal cord and spreads into the anterior commissure. However, the lymphatic metastases are uncommon. Subglottic carcinoma is usually an involvement of the subglottis, but the laryngeal cancer represents inferior spread of the glottic or the supraglottic tumors. However, the lymph node metastasis is more common. So, what do surgeons need from us? Okay. If a surgeon refers the case of the laryngeal cancer to you as a radiologist, you should report all of those. You should report the level, the spaces invasion, either the anterior commissure is affected or not. This will alter the patient surgery. This will alter the patient prognosis. So you need to know the anterior commissure is involved or not. You need to know the laryngeal cartilage invaded or not, the strap muscles, are they invaded or not, and the lymph node metastasis. We'll have some examples of the laryngeal cancer. You can see here, this is an abnormality on the right side of the neck. Which level is this? So we here have the arytenoid cartilage. So we are superior to the arytenoid cartilage. So this is supraglottic tumors. So this is abnormality here. We lost our symmetry. The spaces, the piriform fossa here is invaded. There is an abnormal density here. So this is a cancer in the supraglottic space. Look at the coronal images. This is the true vocal cord. So the whole abnormality here is supraglottic with no glottic or subglottic extension. Those are some contraindications to the classic supraglottic laryngectomy. Yes. At the right side, there is invasion of the paraglottic space. However, more or less patent the pre-epiglottic space. There is something too about the supraglottic tumors. If a normal slice can be found between the tumor but still within the supraglottic larynx, the supraglottic laryngectomy is technically possible. Another example here is the transglottic tumor, and being the transglottic, it means the tumor here in the coronal CT images has descended from the vocal cord, the supraglottic space through the true vocal cord through the infraglottic space, and we can here see that this cartilage, mainly the thyroid cartilage, is more dense, more bright. It means that this cartilage is also invaded. This is the preglottic space, as we agreed it should only contain fat. We can see a soft tissue density here, meaning that there is an abnormal thing here which turned out to be laryngeal cancer invading the preglottic space. Again, we've lost our symmetry here. We are at the level of the true vocal cords lined by the arytenoid cartilage. We can see an abnormal soft tissue density here invading both the anterior commissure as well as the arytenoid cartilage, which appears more bright than usual. If we compare those, we find this more bright than usual, determining that this is an invaded arytenoid cartilage. We here also have a laryngeal cancer which invaded outside the larynx, invading the thyroid membrane and going outside the larynx. Another example here of the cartilage invasion, you can see that this cartilage is markedly thinned with the tumor at both sides of the cartilage, denoting the extralaryngeal extension as well as the cartilage invasion. So the imaging plays an important role in the diagnosis and evaluation of the laryngeal cancer. This includes the imaging anatomy, pattern of tumor spread, and the contribution of imaging in the treatment, staging, and post-treatment surveillance. Thank you.